But it's costing around 2.5 to 6 like that. Now robotic PCI will come someday. It's available in Gujarat in India. Where we can do the procedure by sitting in on this chair. We need some assistant to assist you to change that staying or value. But other things will be the main operator here. So to reduce the burden of radiation and catching all those stuff. And by this machine we can move the state something by millimeter or millimeter, which was not possible with a human hand. But I can't detect this much of precise position. The robot can see and they can do it. And we can do the procedure by sitting in another country or another state and with as a main operator, and we can have a technician there to do those attachments for you. So this is a patient on robotic PCI. So studies done and they have a good success rate and remote PCI can be done. Now coming to stent, the initial stent was like pacemaker. Initial pacemaker was bulky, and with the time now we have this kind of small pacemaker. The technology is evolving, and we also nowadays we having the leadless pacemaker, which we can implant inside the ventricle. So now treatment for heart failure and death, we have one device by different technology. One is the CRTD device in case of dilated cardiomyopathy and blood bundle branch block or white QRS. This case I did in when I came to Kolkata for a long time, and this patient's last follow-up is still doing well. The LV function improved from 25 to 55%. Lady, I did after 1 month of coming to the hospital. So now we are having the pacemaker clinic where we do the ablation of the complex arrhythmia like ventricular tachycardia. Now let us talk about the newer technology, that is the TAVI or percutaneous aortic valve replacement, where we can put a cross that the aortic valve and put a valve in the inside the aortic valve without the percutaneous way. The problem is that now we can include the high risk, moderate risk, also low risk patient as an alternative to surgery. So low risk patient we can include nowadays. The results are good. So it's a new technology where without a patient basically high risk is like LV dysfunction, patient with AKI or kidney disease. So they can do this by percutaneously, and patient can have a patient can be discharged in the 1 or 2 days after the procedure. So this is called TAVI. So it says lower risk of bleeding, and lower risk of acute kidney injury, and new AFib. The problem with this procedure is the vascular complication, chances of having a pacemaker implantation, and residual AR. The more frequent is with TAVI, and there is a shift to include both high risk and low risk patients after 2020. So last 4-5 years, people are doing this TAVI in low risk group also. The problem is paravalvular leak, stroke, vascular injury. Sometimes we need to put another valve after some time, and we need to include the cardiovascular surgeon as a decision maker. Also, we are now having technology to put a percutaneous valve in mitral and tricuspid position, and we have ongoing device innovation regarding this. I am not going to talk much more about it. So this is one is the mitral clip for the severe MR, where we can put a titanium clip inside on the mitral valve, just like clip which can hold both leaflet, and by doing that you can reduce the MR. But issue is that the high cost. Nowadays it cost around more than 20 lakhs. So we cross the mitral valve after the atrial septum puncture. We cross into the left ventricle, and once the position is by TE, you can see that we are holding the leaflet, we just clip it. We are also from the patients with recurrent stroke, we can use the left atrial apparatus closure. So that's we can. There's another device done into the atrial septum. We can put the device into the ill appendage to reduce the chances of stroke in patients where we can't give anticoagulation. Now AI is coming in a big way in our patients. AI will see the echo, AI will tell you the ejection fractions, AI will tell you that this valve need to be replaced or not. AI will see the data from the patient's record history, and they will integrate all this information and will guide you to make a decision. And in the cath lab also, AI will, you can use the virtual thing on that, you can wear a virtual goggles, and AI can tell you this is the valve, you go that way. So we can see the patient on the heart as a 3D inside your eyes. So that will come in the next 10 years. So the AI will include the echo, angiography, cardiac MR, automated plaque plug, like AI will tell this plaque needs to be treated or not, and that will be done in real time in the cath lab. So like angioplasty PCI, AI can help you interpreting the CAG, IGAS, HFR, and OCT. Wearable and remote monitoring, we are now having devices which we can wear on the chest wall, which will tell you whether you are having a tachycardia or bradycardia or VT, VF. We are having a corneal implant which can tell you the blood sugar level. The lens, contact lens on the cornea will measure the blood sugar. The ring on your finger will tell you about your SpO2, your blood pressure, and your arrhythmia. And also there is some implant coming in the brain which you can talk to from the brain. You can talk to your all the devices, and you can detect. It tells your devices to do what, to give insulin or not. So future trend in interventional cardiology, having a nanotechnology to miniaturization to make everything small, and it will be global. US doctor will help you out in Indian patients by robotic PCI, sitting in New York doing PCI in Busan or somewhere else. And genetic technology, integration of the artificial intelligence will come in new way, will guide us whether to treat this patient or not by integrating all the data from the echo, from your cath lab, your cardiac MR, your patient history. The patient will talk to the AI will collect all the data, your blood sugar, so they will ultimately give you their opinion. So thank you all.
Thank you, Dr. Patra. So, and in continuing with the recent lecture, I invite Dr. Avik Bhattacharya. He will speak on the intervention radiology.
And about that, sir, we have to make the felicitation. So,
Sorry,
all the three chairpersons, please do join. Our respected chairpersons, please do join to felicitate Dr. Patra. And I will invite Dr. Sarkar. Our eminent physician of Kolkata, Dr. Sarkar is here. Dr. Sarkar. Thank you.